All right, welcome to our guide on a really critical part of HIV care, how to prevent and manage opportunistic infections. We've put this together specifically for you, the practicing pharmacist, to make this whole area just a little more straightforward. So let's get right to it. Why is this so important? Well, this number here tells you pretty much everything you need to know. Up to half, that's half, of all new HIV diagnoses happen in what we call late presenters. These are folks whose immune systems have already taken a pretty big hit. And that leads us to a really important question. What is it that finally pushes many of these patients to come in and get care for the first time? Yeah, for so many of them, it's an active opportunistic infection. And that right there is why your role is so vital. Being able to recognize the signs, understand the risks, and help manage these OIs is absolutely critical from day one. Okay, so if we're going to get ahead of these infections, we need a game plan. And our anchor for that entire plan is the CD4 count. It's like our roadmap. It tells us exactly which pathogens we need to be on the lookout for and when. So when a patient's CD4 count is above 200, things are looking pretty good. Their risk for most OIs is relatively low. Here, your focus is really on routine care, making sure they're up to date on standard vaccines like for the flu and pneumococcus. But the moment that count dips below 200, the whole landscape changes. This is a major turning point. The first big risk pops up on our radar, pneumocystis pneumonia, or PCP. This is our signal to get that patient started on primary prophylaxis. And as we go lower, the danger ramps up. If a patient's count drops below 100 times and they happen to be Toxoplasma IgG positive, we're now worried about Toxoplasma encephalitis. That's a really serious parasitic brain infection. And finally, below 50. This is the real danger zone, the most advanced stage of immunosuppression. At this point, we are on high alert for things like Mycobacterium avium complex, or MAC, and even sight-threatening diseases like CMV retinitis. Knowing the risks is one thing, but preventing them is the real goal. So let's open up the pharmacist's prevention playbook, and we'll start with some crucial advice that has nothing to do with pills. This is such a perfect example of how simple advice can literally be life-saving. Counseling on good hand washing, food safety, and avoiding environmental risks, like cat litter, which is a big one for toxoplasma, these are powerful interventions you can lead. Okay, now for the meds. What's so great about this table is how elegantly it simplifies the guidelines. Just look at how efficient this is. One single drug, sulfamethoxazole/trimethoprim, covers us for both PCP and toxoplasmosis. Then, once the CD4 count drops below 50, we just add a macrolide, like azithromycin once a week, to cover for MAC. It's pretty straightforward. Prophylaxis is our first line of defense, our shield, but it isn't perfect. So we also have to be ready to put on our detective hats and recognize the signs of an active infection when a patient shows up with symptoms. Let's focus on the usual suspect, PCP. The classic signs you need to watch for are a fever that just won't quit, a nagging dry cough, and shortness of breath that keeps getting worse over days or weeks. If you hear that combination, that's a huge red flag. And here's the best part. Our go-to for prevention is also our gold standard for treatment. It's the same drug, sulfamethoxazole/trimethoprim. We just use a much higher dose and run it for a full 21-day course. This slide right here, this is your wheelhouse. This is where your expertise is absolutely essential. You're the one counseling on common side effects like rash, you're warning about the risk of high potassium, especially with those treatment doses, and most of all, you are stressing how critical it is to stick with it for the full 21 days to completely wipe out the infection. Okay, let's talk about a concept that can feel a little backward, but it is so important to understand. It's called immune reconstitution inflammatory syndrome, or IRIS. It's a paradox. A patient starts ART, their immune system starts to recover, and then, all of a sudden, they feel worse. It's because their newly awakened immune system finally sees a hidden infection and launches this massive inflammatory attack. So what do you do when IRIS happens? There is one absolute golden rule. Do not stop the life-saving therapies. You have to keep the ART going and you have to keep the OI treatment going. The goal is to just manage the fire, the inflammatory response, often with something like NSAIDs or corticosteroids, while the other drugs do their job. All right, let's bring it home with a few high-yield counseling pearls and special cases that you're definitely going to see in your practice. You're going to hear these two terms all the time, so let's just make sure we're totally clear on the difference.
Primary prophylaxis is what we use to prevent that first infection in a patient who's at risk. Secondary prophylaxis is what we use to prevent a relapse after a patient has already been treated for an OI. Think of it as maintenance therapy. Now for one of the best parts of the job, deprescribing. This slide shows you exactly when it's safe to stop these extra medications. Once ART gets that immune system back on its feet, we can take them off. For PCP and Toxo, the magic number is a CD4 count over 200, sustained for at least 3 to 6 months.
And what about pregnancy? Well, this definitely brings some unique challenges, but the number one goal is exactly the same: get that viral low to undetectable. We can still use SMX/TMP, but you'll want to carefully weigh the risks and benefits in that first trimester, and always add folic acid. For MAC prophylaxis, azithromycin is our preferred choice. I want to end with this quote because it really gets to the heart of everything we've talked about. The work you do in counseling for adherence to antiretroviral therapy, that is, without a doubt, the single most powerful tool we have for preventing OIs. Full stop. So, we've walked through the key numbers, the drugs, and the counseling points. The final step is really up to you. It's about taking this knowledge and weaving it into every single patient interaction. Your vigilance can prevent an infection, and your counsel can change a life.